Good evening. Thank you for joining us. Welcome to solving the multimodal puzzle of head and neck cancer in the immunotherapy era, how evidence is driving practice changes. I'm Ezra Cohen from University of California, San Diego Moores Cancer Center. And with me today are two people who really don't need much of an introduction, I'm sure, to this audience because of their expertise in this disease and especially around immunotherapy. Barbara Burtness from the Yale Cancer Center in New Haven, Connecticut, and Dr. Andrew Sharabi from the University of California, San Diego, one of our wonderful radiation oncologists at our facility.
The following audio is part of a certified educational activity. Access the entire activity and complete the post-test at www.peerview.com/QES. Downloadable slides and practice aids are also available.
We know that this is, and really around this conference, a multidisciplinary disease that is treated with surgery, radiation, chemotherapy, of course, in many cases, and somewhat recently, although now more than a decade ago since its approval, cetuximab or other EGFR inhibitor agents. And now, recently, immunotherapy has come to become a part of the treatment of squamous cell carcinoma of the head and neck, and we'll share the data and talk about it. Immunotherapy may have the potential to improve outcomes. We'll talk about that. It may allow us to develop more effective combinations, and in some cases, even replace other forms of systemic therapy or other forms of multimodality therapy. These are the approvals for immunotherapy agents in squamous cell carcinoma of the head and neck. Pembrolizumab, of course, an anti-PD-1 antibody. Nivolumab, also an anti-PD-1 antibody, both approved for recurrent metastatic squamous cell carcinoma of the head and neck. The wording is a little bit different, but essentially after a platinum-containing regimen. At the bottom of the slide, you see some of the ongoing phase 3 studies in different lines of therapy in this disease, and we'll talk about those in greater detail. And so tonight's agenda really covers the latest updates for evidence for immunotherapy in head and neck cancer, a look at patients and their viewpoints, and we'll talk about some of the practical issues in treating patients. And in fact, you'll see a video of a patient who has been treated. And then we'll talk about integrating immune checkpoint blockade with radiation and other modalities such as surgery. And so let me reintroduce Dr. Burtness from Yale University School of Medicine, Yale Cancer Center, who will be talking about getting immunotherapy right, interpreting practice-changing evidence. Thanks, Barbara.
This is an incredibly fast-moving field, and so there are actually quite a lot of data, even though we've only been studying immunotherapy in head and neck cancer for about 4.5 years now. I'll start by saying that head and neck cancers are somewhat immunogenic. We know that T cells can infiltrate head and neck cancers, whether they're HPV positive or HPV negative, that there's evidence for T cell exhaustion, and that those cancers that are infiltrated by T cells or by Tregs have better survival. So this was one of the first observations that made people think that as immunotherapies were coming on board, that head and neck cancer ought to be looked at. And then the second was the observation that squamous cell cancers of the head and neck have a fairly high mutational load. And what you can see from this schema here is that when you look at the number of mutations per megabase, whether you're looking at patients who are smokers or non-smokers, who are HPV related or HPV negative, or across the anatomic sites of hypopharynx, larynx, oral cavity, or oropharynx, there are a high proportion of these cancers that have a high mutational load. And just to jump ahead to some of the data with immune checkpoint inhibition in head and neck cancer, when you look at mutational load and you associate it with best observed response in both HPV positive and negative cancers, it appears as if higher mutational load is associated with greater sensitivity to pembrolizumab. So the first thing that I'll do is I'll go over some of the trials that demonstrated that these agents have reproducible single-agent activity in head and neck cancer. And the first large cohort of head and neck cancers patients was accrued to the KEYNOTE-012. This was an expansion trial. It also had triple-negative breast cancer and bladder cancer and esophagogastric cancer in it. But the head and neck cancer cohort accrued patients who were both HPV-driven cancers or HPV-negative cancers. In the first cohort, which is often referred to as B1 in the presentations, patients had to have evidence of PD-L1 expression, so the ligand for the PD-1 receptor had to be present either in tumor or tumor-associated lymphocytes. Then in an expansion cohort, they accepted all comers, and this trial used initially a weight-based dosing and then went to a flat dose. The objective response rate was 18 to 20% for the two cohorts. The median duration of response was not reached, and as you can see, even among those patients who did not have an objective response, the majority of patients saw some shrinkage in their measurable disease. I will point out too, and this is something we'll talk about a little bit more, there are some patients who have pretty dramatic progression early on. If you looked at the median time to response, it was about 4 months. The responders are these yellow triangles. There were patients who didn't achieve their response till after a year. And looking at these spider plots, you can see that the majority of patients saw regression of disease. But again, I'll just point out a couple of patients with rapid progression. And the reason that I'm kind of coming back to this is that people may be aware of the phenomenon of pseudoprogression, where early on in the treatment with an immune checkpoint inhibitor, there appears to be at least radiographic progression of some lesions, which is followed by response. And that number is put at about 6% for melanoma. We believe that it's under 0.5% for head and neck cancer. And as you look here, you only actually see one patient in this spider plot who had initial RECIST progression and then responded. And this is just a caution. If you're treating a patient who has symptomatic progression, it's not like melanoma. You don't necessarily want to hang on for the 16-week scan. The KEYNOTE-055 trial was a second single-arm study with pembrolizumab in patients with recurrent or metastatic disease. This was for patients with cisplatin and cetuximab refractory disease. And again, response rate of 16% was seen. The overall response rate was about the same in HPV positive and HPV negative, but I'll point out that those patients with early progression, more common in the HPV negative. This again shows a large number of patients deriving benefit even if they didn't have a RECIST response, and again, the long duration of response for the responders. Durvalumab is a monoclonal antibody directed to the ligand, to PD-L1, and this has also been tested in head and neck cancer. This shows you that for patients with PD-L1 high or PD-L1 low tumors, there were responses that were confirmed in both groups. And we now also have phase 3 data that confirm the role of PD-1 blockade in head and neck cancer. And the first paper to highlight is the Checkmate 141, reported by Bob Ferris in the New England Journal of Medicine 2 years ago. This was a study for patients with recurrent or metastatic disease of the big 4 sites, oral cavity, oropharynx, larynx, or hypopharynx, who had good performance status, were not amenable to curative therapy, and had progressed within 6 months of their last platinum-based chemotherapy. So that could have been first-line therapy for metastatic recurrent disease, and now they were requiring second-line therapy, or it could have been patients who were initially treated with platinum radiation for locally advanced disease and then progressed early, and we know that to be a very difficult group to treat. Patients had to have documentation of their HPV association, no active brain metastases, and they were stratified by prior cetuximab treatment. They were then randomized to nivolumab or an investigator's choice standard of care, which could be methotrexate, docetaxel, or cetuximab. Primary endpoint was overall survival, and overall survival was significantly improved with the use of nivolumab. So with investigator's choice, it was 5.1 months. With nivolumab, it was 7.7 months. And I think what's striking is the durability of this improvement. So you look at 12-month overall survival going from 19.5% to 34%, and 18-month survival going from 8% to 21.5%. Adverse events that were seen in more than 10% of patients differed between the arms. So overall, grade 3-4 toxicity was less common with nivolumab than with investigators' choice. And then looking at some of the things that might have been a little bit more common with nivolumab, you see some pulmonary toxicity, but at a low rate. When you looked at overall survival by PD-L1 expression, the difference was much more dramatic for the PD-L1 expressing cancers. So investigators' choice, median overall survival of 4.6 months going to 8.7 months, hazard ratio there 0.55. And then for the patients who had low PD-L1 expression, although there is a tail on the curve here, the median did not really change, 5.7 versus 5.8. Hazard ratio here 0.89, and the confidence intervals crossing 1. If you looked at the difference by P16 status, there was a benefit for the use of nivolumab over standard of care therapy for both groups. I'll point out that the P16 positive group here was apparently quite an aggressive group of patients. Maybe these were the ones who had had very early progression after locally advanced disease therapy or had had more lines of therapy. But it's not typical for us to see that the median overall survival is shorter for the HPV positive than the HPV negative. Keynote 040 study, which is Dr. Cohen's study in which he presented at ESMO last year. This was a similar design, pembrolizumab versus standard of care for patients who had progressed after platinum-containing therapy, had good performance status, known P16 status, had tissue available for PD-L1 assessment, and I think a really thoughtful set of stratification factors here of performance status, P16 status, and those patients who had very richly PD-L1 expressing cancers. There were 495 patients who were randomized 1-to-1 between pembrolizumab and standard of care. There were 246 versus 234 treated, and the patients who discontinued in the pembrolizumab arm did so for progression of disease, adverse events, or consent withdrawal, and likewise in the standard of care arm. And so here you see the initial report of the overall survival. Our understanding is that there may be a few more events coming in, and these data may be updated perhaps at AACR. But what you see here is a hazard ratio of 0.81 favoring pembrolizumab over standard of care with a p-value of 0.02, median survival going from 7.1 to 8.4 months, and the one-year survival going from 27 to 37%. For those patients who had PD-L1 expression, and this CPS refers to combined positive score, so PD-L1 could have been in the tumor cells or it could have been in the tumor-infiltrating lymphocytes, and you can see here that the hazard ratio is a little bit more striking at 0.75, and median survival, again going up, overall survival 40% for these patients at 1 year. And looking at the patients who have more than 50% PD-L1 expression, hazard ratio here 0.54, and 1 year survival of 46.5% for that group. Looking at overall survival in subgroups, by and large, all of the subgroups appeared to benefit. The one little outlier here, and it still crosses one, is the group in North America, and these were probably the patients who were most likely to have access to nivolumab or pembrolizumab at crossover. Looking at the response rate, this did also go up for the patients who had higher PD-L1 expression. These swimmer plots are very reproducible from one study with PD-1 inhibitor to another, and so you see that for those patients who have responses, the responses tend to be quite durable. There were some differences in this study in terms of subsequent therapy. So you can see that in the pembrolizumab arm, 4.5% of patients got subsequent immune checkpoint inhibition versus in the standard of care arm, 12.5% did. And if you looked at overall survival on the basis of whether or not patients got subsequent checkpoint inhibition, the median overall survival for those patients was 20 months as compared with 9.8 if they got a different subsequent therapy and 4.6 if they got no subsequent therapy. Immune-related adverse events, hypothyroidism is very common, but of course these are head and neck cancer patients, many of whom had prior chemoradiation for locally advanced disease, and hypothyroidism would be common anyway. Pneumonitis, infusion reactions, skin reactions, and Guillain-Barré syndrome, kind of some of the other standouts. So with Keynote and Checkmate 141, in both cases we had evidence that the immune checkpoint inhibitor performed better than standard of care. This met the prior statistical test in the Checkmate study and not in the Keynote study. Are there particular factors that might explain this? First of all, the stratification variables were different, but to me the most striking thing is what were the physicians choosing as second-line therapy? So in the Checkmate study, 38% got methotrexate, 21% got docetaxel, and 11% got cetuximab, whereas in the Keynote trial, only 27% got methotrexate, and then 42% got docetaxel, 30% cetuximab. Likewise, there was a pretty significant difference in the number of patients who had had 3 or more prior therapies, 1.2% in the Keynote study, 22.5% in Checkmate, and we don't know the rate of post-trial immunotherapy on the standard of care arm in Checkmate 141, but just in terms of secular trends, there wasn't a PD-1 inhibitor on the market for head and neck cancer at the time Checkmate was being conducted. What about combinations of immunotherapies with other agents which might impact the immune system? And I think we're all pretty excited about the IDO inhibitors at the moment. So just to set the stage for this a little bit, the whole field of immunotherapy is concerned with how tumors are evading our normal immune surveillance mechanisms. And IDO1 is a particular enzyme which plays a role in this. It's induced by interferon gamma, and it catalyzes the rate-limiting step of tryptophan degradation in the kynurenine pathway. And so then you have depletion of tryptophan, production of kynurenine, and this shifts the local immune environment into a somewhat more immunosuppressive state. Epacadostat is one of the drugs that's currently under development for this, being a potent inhibitor of IDO1, and so there's been curiosity about combining epacadostat with other immunotherapy. And the first study that we've seen with this in head and neck cancer is the Keynote 037. This started with a dose escalation phase, so epacadostat initially given at 25 milligrams twice a day and then escalated up to 300, then going through a safety expansion. The recommended phase 2 is epacadostat 100 milligrams twice a day with pembrolizumab, and there were a number of tumor cohorts. Just to dive in deeper on the head and neck cancer cohort here, so if you look at objective response rate for patients treated with pembrolizumab and epacadostat, it was 34%, and this was somewhat higher in the patients who were not as heavily pretreated. It looked a little bit higher in the patients who weren't as richly PD-L1 expressing. Maybe there was more room for the IDO to make a difference in their immune microenvironment, and then not affected by HPV status. And strikingly different from data in other diseases, for example, nivolumab, ipilimumab combination, where multiple immunotherapies appears to increase the likelihood of immune-related adverse events. Here there were no immune-related adverse events of grade 3-4 among 38 patients, although some hypothyroidism, adrenal insufficiency, and pneumonitis were noted. The next study I'm going to talk about has a little bit more complicated design. It starts with durvalumab, which is a PD-L1 inhibitor, and then looks at combining it with a STAT3 inhibitor, STAT3 being a signal transduction molecule that broadly modulates immune system function, as well as potentially having some other anti-cancer effects in head and neck cancer. And CXCR2, which modulates marrow myeloid cell release. And so there we have these two agents, AZD9150 and AZD5069, which respectively target STAT3 and CXCR2. And then you see this design, they're being dose escalated in combination with durvalumab. And the phase 1 part of this looks at dose, PK, and safety, and then the phase 2 is going to look at response rate. Just looking at some early data from this in the PD-L1 pretreated patients, and so this is quite striking, right? Patients who had previously failed immune therapy, still seeing an 11% response rate, and then in the PD-L1 naive patients, the addition of the STAT3 inhibitor leading to a response rate of 29%. And then again, just to focus in on the naive patients, you can see here that some of these responses were in fact quite striking and quite durable. Another combination immunotherapy that's being developed specifically for the HPV-positive patients looks at the use of a HPV-directed vaccine. We have this open at my center. There's a attenuated listeria organism that's been modified to link an E7 vaccine, so E7 being one of the HPV viral oncoproteins, to a listeria toxin, and then this is given together with durvalumab, currently accruing in cervical cancer, anal cancer, and squamous cell cancer of the head and neck. And then there's some big studies that I think have either recently completed or are still accruing that we should be keeping our eyes open for. And the first I'll mention is the EAGLE study. So this takes durvalumab, the PD-L1 directed antibody, and looks at it with or without the combination with the CTLA-4 antibody, tremelimumab. And so you have here patients randomly assigned in the second-line setting to standard of care, durva monotherapy or durva with tremi. This study has completed accrual, but is not yet reported out. And then a very similar design in the first-line setting. So a study for patients who have not had previous systemic therapy for recurrent or metastatic disease, and then randomly assigning them to the PD-L1 antibody alone, the PD-L1 antibody plus the CTLA-4 antibody, or our old friend, the extreme regimen, as the FDA's favorite active comparator, although not our patient's favorite active comparator, probably. Keynote 048 is another recently completed trial, and this looks at the very interesting question of can you combine immunotherapy with chemotherapy? And a couple of pieces of rationale here. One is I've talked a couple of times about those patients who have early progression. Would it help control their disease until the immunotherapy can kick in to have some chemotherapy on board? But second of all, some of the things that chemotherapy can do in terms of both leading to shedding of tumor antigen as cancer cells die, and also when you're using an agent like platinum that produces DNA damage, leading to novel mutations, would you actually be creating a better environment for a durable response to immunotherapy? So this is a large trial, recently completed accrual, and hopefully we'll be reading out later this year or early next year. And then Keynote 669, ECHO 304, is a trial that's currently accruing. And this goes back to epacadostat, the IDO1 inhibitor that I showed you in the phase 1, phase 2 trial. This is a phase 3 randomized open label study for patients with recurrent and metastatic disease who are at least 6 months out from their primary therapy. They have to have good performance status. If they have oropharynx cancer, we have to know their HPV status. They have to have tumor that's available for PD-L1 testing. And then the primary endpoints are overall survival and progression-free survival. This is a randomized comparison of pembrolizumab plus epacadostat versus pembrolizumab versus the extreme regimen. Checkmate 651 looks at nivolumab, so one of the agents that's already FDA approved in this disease, with ipilimumab, a CTLA-4, and again using this combination that we've seen a fair bit of in melanoma and non-small cell lung cancer, and comparing that head-to-head with the extreme regimen in patients who have not had prior systemic therapy for recurrent metastatic disease. So just to wrap up this section, I think the conclusions that we wanted to highlight, that single-agent anti-PD-L1 or anti-PD-1 therapy is active and effective in squamous cell cancer of the head and neck, and approval is granted in the United States actually for the two PD-1, not PD-L1, two PD-1 inhibitors, pembrolizumab and nivolumab. There are a number of combinations targeting immunosuppressive tumor microenvironment that appear promising, and IDO1 inhibitor epacadostat and the AZD-STAT3 inhibitor fall into that category. There are many more combinations capitalizing on other mechanisms that are moving forward, and there are phase 3 trials in the frontline setting that are completed or near completion with results expected in the coming year.
All right, so let's now talk about integrating immune therapy into patient management for recurrent metastatic disease, and really first begin with a patient video and then get into discussion of some of the practical issues that all of us face when treating patients. So let's watch the video.
My name is James Lyons. I'm 73 years old, and I'm a retired Bridgeport police detective. I am a fighter. I don't know whether it's the Irish in me or the Polish in me. I had a lump on my throat, which I had noticed, shaving, and I didn't think anything of it because I had a lump on my chest. When they took it out, they just drained it and it was nothing. It was benign. So I thought that was the same with my neck. But as it got bigger, I said, something's wrong. So in May of 2016, I went to see a dentist who sent me to a surgeon, oral surgeon, who then sent me to this head and neck doctor. And that's when I found out I had tongue cancer. I had 3 cancers. First time was colon cancer. Second time was prostate. I beat it twice before. What do? I had tongue cancer. And I was going to have radiation and chemo. So I had 33 days of radiation. I had 2 sessions of chemo, and they said it wasn't working. I looked like I was on my way out. I said, well, what's next? What are we going to do? And the doctors I have are great. And that's when they brought up immunotherapy. It's fairly new. I go to Yale, then they take my blood, whatever blood work has to be done. Or they put me in a chair, and that's when they order the cocktail. And that usually takes most of the day, 6, 7 hours. Originally, I was supposed to have 6 sessions, at 1 session every 3 weeks, and I'm up to 18 now. When I started immunotherapy, I lost a lot of weight, which was, I guess, expected. I was on a feeding tube in the beginning because I couldn't swallow. And that's where I lost the weight. Once I got off that, I started eating and gaining weight. Being on a feeding tube for the first time was horrible. I went from 180 to 130, and now I'm working my way back up. I'm 149. Well, I knew that was going to be one of the side effects because they said I would have diarrhea, which I did for a short time. I took care of that. And then the only other side effect I had was a rash on my neck. And they weren't sure whether it was from the treatment or the radiation. The tongue cancer is, as far as I know, is gone. Immunotherapy, it's helped me immensely. I don't think I'd be here today if I didn't have it.
It's an amazing story, and I think a lot of aspects of what this gentleman went through and experienced are probably familiar to many of us who treat these patients. The difficulty with curative intent therapy, the aggressiveness of that, and really the hope that now immunotherapy is beginning to offer. So is Jim's experience a model for how different modalities are being used for patients with head and neck cancer? Barbara, what do you think?
So I think that there are a couple of things that stood out. One, it sounds like he needed a clinical trial to get immunotherapy at the time that he started. Second of all, he had been through standard treatment with chemoradiation for locally advanced disease and then recurred. So that's exactly the setting in which Pembro and Nivo are approved. And obviously he's done very beautifully. So that's great.
Yeah, so Andrew, I know you're going to talk about this a little bit with respect to the interaction between immunotherapy and radiation. Is it beginning to change the way you think about radiation and how you might use radiation with the treatment of patients?
Yes, yeah, definitely. I think it's a great example of how therapies could potentially be combined, and what the role is of that prior treatment that he had, the chemoradiation, and potentially downsizing the disease, and then potentially allowing for immunotherapy to work a little better. So that's one important potential avenue.
Yeah. And then let's talk a little bit about some of the side effects that he had and some of the adverse events that I think we've all seen as we begin to use these agents more and more. He talked about diarrhea. He talked about a rash. Barbara, I'll turn it over again to you first. What do you think? What do you tell patients to expect, and how do you practically think about adverse events with immunotherapy?
So we tell patients to expect a 9 to 17% rate of grade 3 adverse events that are immune-related. And my own feeling is that in my practice, pneumonitis is probably the one that's most common, and it may be that the neck field hitting a little bit of the lung, I think the non-small cell lung patients who have radiation also have a higher rate. We do certainly see diarrhea. We've seen rheumatic complaints, myositis, and obviously the whole gamut of the less common things, hypophysitis. We mentioned hypothyroidism a little bit earlier. Obviously, 40% of the patients who get a standard neck field are going to end up with radiation-induced hypothyroidism. The management isn't that different for a low-grade immune-related hypothyroidism. He did mention being on a feeding tube. We didn't hear exactly how he recurred, but my guess might be that that was his recurrent disease that was impacting his swallowing, and it was actually the response that allowed him to come off.
To perhaps come off the feeding tube, which is really interesting. And then Andrew, let's talk about clinical trial enrollment for a moment, and how you view patients in this scenario. Granted, none of our patients actually fail at UCSD, but let's imagine that that does happen. When do you think about clinical trials? How do you think about it? How do you approach patients?
Sure, absolutely. Yeah, I mean, I think at this point for a definitive treatment, for upfront treatment of head and neck cancer, I think a clinical trial option should be the standard if available, and there are a number of trials that I'll be discussing that can incorporate immunotherapy into the upfront curative management of head and neck cancer. And then also for patients that have gone through a prior course of treatment, a definitive surgery or a definitive chemoradiation in the past. There are certainly a number of trials available now for using immunotherapy in those settings, which we'll also be discussing. I would like to just touch back on the adverse events, though. Just listen to his story, how going through that course of chemoradiation was quite difficult. Okay, it's a very intense treatment, as many of you all know, and I think we should take that into light as we're adding treatments to that. Potentially adding immunotherapy concurrently with chemoradiation, and you get additional potential toxicities. But at the same time, looking how some of these treatments or immunotherapy could potentially be used to de-escalate treatment and improve that side effect profile, especially in elderly patients. So I think that's a key piece going forward.
Yeah, and Andrew, I think you're going to talk about explorations in all of those realms during your discussions. So once again, we do have 2 anti-PD-1 antibodies approved for recurrent metastatic head and neck cancer. The first drug I'll talk about is nivolumab, dosed in head and neck cancer at 3 milligrams per kilogram. Although I confess I use the flat dosing. I don't know, Barbara, do you use the weight-based or the flat dosing for nivolumab?
Currently, we have the 714 trial open, so
you follow whatever. Yeah. Good to hear that patients are being enrolled on clinical trials. And then, of course, the other drug is pembrolizumab, also anti-PD-1 antibody. Here, it is a flat dosing based on comparative data, not randomized data, but comparative data between a weight-based and flat dosing, 200 milligrams every 3 weeks. And there you see the other parameters about administration. Let's make a couple of points about adverse events just before we leave this segment. And as both Barbara and Andrew alluded to, immunotherapy, we now know, can affect any system in the body. There are ones that we see more commonly. We talked about the endocrinopathies. We talked about pneumonitis with anti-PD-1 or PD-L1 antibodies. But we have seen everything, essentially, or everything has been described, from the common ones that we talked about to rare ones like myocarditis, type 1 diabetes. And so we've really, in a sense, have had to have a high vigilance for these side effects. We've almost become rheumatologists in a way, looking for itises in our patients. And what we tell patients is essentially, if you're having a symptom that is different from your baseline, we want to know about it sooner than later. And certainly if you're having any respiratory symptoms, we want to know about it right away. Or if you have a blistering rash, we want to know about it right away, because those are potentially life-threatening events. So it's high vigilance, it's early detection, and it's early management, and it can happen anywhere. In terms of the practical points with respect to management, for grade 1, it's really the ability to continue the immunotherapy and control the symptoms. Rash would be a very good example of that. We often continue the immunotherapy and prescribe something or even some over-the-counter remedies for the rash. For grade 2, now getting a little bit more severe, we withhold the chemotherapy and we start steroids. It's really important that for immunotherapy at a grade 2 level, we are now actively intervening and doing something to downgrade or to reduce the toxicity. It's important to remember that. The other thing to remember about steroids in this context is the taper should be slow. These are not pulse steroids. This is start the steroids and taper very slowly over a period of 4 to 6 weeks. And then, of course, redose the immunotherapy as the toxicity resolves. For grade 3, 4, really these are serious toxicities, could be life-threatening toxicities, and the practice should be to discontinue the immunotherapy. Unfortunately, that is a situation where the individual is having an autoimmune effect, an on-mechanism, an off-target effect, and immunotherapy should be discontinued. High-dose steroids should be started, and again, that slow taper. And there are other measures that can be taken if, of course, the high-dose steroids don't work, and we can talk about that if there's interest. And so really the future of immunotherapy in head and neck cancer, I think, largely depends on clinical trials. It's important to think about that. We have to think that the percent of patients entering clinical trials in the United States of the adult population is really dismal, and yet we know that in order to move our field forward, we have to have patients participating in clinical trials. And so we really need to get that number higher as a community. There are many, many open trials. If you do a search on, for instance, clinicaltrials.gov and type in immunotherapy in head and neck cancer, you will literally get anywhere from dozens to a couple of hundred studies, depending on how you do your search. In fact, some have argued that there are more trial slots than there are actually patients with some of these diseases. Nonetheless, we are eager to investigate many of these combinations and new settings. And then lastly, we have to raise awareness, I think, of clinical trials to patients, to the community, among physicians, among practitioners, and it's important that we realize that the studies are out there. So we really, from a viewpoint of trying to move the field forward, should always be considering trials, and fortunately both the NIH and the NCCN have recognized this, as well as ASCO. So here's just a selection of ongoing studies. Some of these you've heard about, some of these you will hear about. With nivolumab, we have studies that combine it with ipacadostat. This is the IDO inhibitor that Dr. Burton has talked about, as well as a trial in the upfront setting combining with either chemotherapy or versus cetuximab radiation. Andrew will talk about that. And for pembrolizumab, we have studies that, again, combine with other immunotherapies. Here you see ipacadostat as the example, and test in the front line, such as Keynote 412. PD-1 antibodies are not the only ones being investigated, by no means. Avelumab is now engaged in a large upfront study called Javelin in the context of chemotherapy radiation, and in Europe a somewhat similar design called the REACH trial. And of course durvalumab also very heavily investigated in this disease in the upfront setting in platinum ineligible patients, a key population for us, and as well as prior to surgery and adjuvant therapy in the context of chemotherapy and as an agent alone. And so with that in mind, that's a great time to turn the lectern over to Dr. Sharabi, who will be talking about immunotherapy, radiation, and surgery as new partners in care, sort of flipping that paradigm. Thanks, Andrew.
Thanks, Ezra, and it's really a pleasure to speak to you all. I want to thank the peer review organizers as well. Also want to thank Quinn Lay for some of her slides, which I used from this deck. But I'm a radiation oncologist. I'm also an immunologist. And I really like the title of this because it is truly a puzzle at this point. And putting them together, there's been three main cornerstones and pillars of cancer care. Primarily surgery, radiation, and then cytotoxic systemic agents. But as Barbara and Ezra so nicely reviewed and demonstrated, immunotherapy is now a fourth cornerstone, a fourth pillar in the armamentarium to fight cancer, and has clear activity in head and neck cancer. So the real question is, how do these integrate? Now that it's demonstrated activity in recurrent and metastatic setting, how do we integrate that into upfront treatments, into earlier stages of disease, and incorporate that with the standard and conventional treatments for cancer? And it is a nice puzzle at this point. So we'll be going over a number of preclinical data. There is less known about how best to go about this. But another point that I'd like to make is clearly I'll focus on immunoradiation, which is immunotherapy combined with radiation. But immunotherapy is a very broad term. There's many different immunotherapies and types of immunotherapies. For example, bacterial adjuvants, such as BCG. This is for bladder cancer. Is actually one of the longest used immunotherapies for cancer. Cytokines, interferon, IL-2 are used. Antagonistic antibodies, which are the traditional checkpoint blockade agents, which I will be focusing on. But DC vaccines are approved. There's a first-in-class oncolytic vaccine for melanoma, which was improved. The agonistic antibodies, these are other molecules and small molecules and antibodies which try to stimulate immune responses are on the horizon. CAR T cells have now been approved, and TIL therapy is on the horizon as well as small molecule immunotherapeutics. So immunotherapy is a very broad term. In this talk, I'll primarily be focusing on the antagonistic antibodies, so-called checkpoint blockade. This is a figure we published, and try to understand how does radiation do this? How can radiation potentially augment immune responses? And there's a number of key steps which we've demonstrated in using radiation primarily as a potential vaccine to incite immune responses or stimulate antigen presentation. And the mechanism has been quite clearly shown that radiation can cause immunogenic cell death, or ICD. And traditionally, to induce an immune response, you need pathogen-associated patterns, such as bacteria, viral signals, to tell the immune system that there's some foreign danger. But in this case, you can have so-called damage-associated molecular patterns. So due to DNA damage, to genotoxic stress, the cells will also express molecules to activate the immune system, which are called damage-associated molecular patterns. In this case, HMGB1, high motility group box 1, can activate the toll-like receptor to cause dendritic cell maturation and activation. It's boosting this antigen-presenting cell. The dendritic cell can take up the antigens and then it migrates to the lymph node, and can present those antigens directly to CD4 helper T cells, or can cross-present those antigens to the CD8 killer T cells, also to other cells as well, to demonstrate immune responses. And we've demonstrated all these steps in preclinical data. So I'd like to take 2 points to understand the two sides of this coin. Using radiation, treating a single site in the metastatic setting as an in situ vaccine, almost as a vaccination approach, in attempt to try to boost the response to immunotherapy. And this is so-called abscopal effect. So where the patient's receiving immunotherapy, we add in radiation to a single site, and that may help to control these other sites by boosting an immune response. Okay, that's one setting. But the flip side of that coin is in the definitive locally advanced setting. And here, it's a radiosensitization. So very similar to chemoradiation, where chemotherapy is used to radiosensitize, just make the radiation work better. In this case, can immunotherapy work that way to make the radiation work better in the definitive setting? So here you have radiation, it's not a non-metastatic disease, and can that improve the local regional control or cure rate? So understand that these are flip sides of the coin, but need very different strategies to address, and two different, very different questions, which are both being addressed independently. So overview, really, the talk, I'll start off going on of the rationale, some preclinical data, ongoing studies adding radiation to immunotherapy in the metastatic setting, abscopal response. I'll then go over radiation and immunotherapy in the definitive setting. And then, as well as I'll discuss surgery, touch on some studies looking at how immunotherapy can combine with surgery, as well as then touch on some safety considerations and the multidisciplinary care that we need for head and neck cancer. So starting off in the metastatic or oligometastatic setting, what is some of the evidence or preclinical data that radiation can actually enhance immune responses? And this is some of that. This is what we published in this melanoma model. These are tumor growth curves, and you can see it's interesting that in many of these models, the PD-1 antibody or immunotherapy alone doesn't do that much, even though these are syngeneic models. But radiation can help to kind of slow the growth and control it. But when we add in immunotherapy, in this case, we saw a significant improvement in that tumor control. So this would be evidence of a radiosensitization. But why that was occurring and why did we get improved survival of these mice, we think is because there's a significant increase in immune responses. So this is looking specifically at pentamer-positive T cells. We know they're specific for the tumor, and you can see a significant increase with that combination. So that's part of the mechanism. We've also shown in models that if you put in two tumors in a mouse and you treat one with radiation and shield the other one, you can see that distant effect or abscopal response, which is due to these immune cells. So I was using single high-dose fraction radiation, but what about more conventionally fractionated radiation? When we treat patients with head and neck cancer, in the definitive setting, we typically use 1.8 to 2 gray fractions, small fractions over about 6 weeks, 30 to 35 treatments. But this study by Dovetti et al., he's published some of the very nice data on kind of fractionation and timing. You can see also a similar effect. This is 2 gray fractions. It's pretty hard to get a technician or research assistant to treat a mouse for 30 treatments, but in this case, they did 5. And you can see an improvement in survival in these mice that receive that conventionally fractionated radiation. So evidence that that can work with conventional radiation. But the story gets also complex, and I think this is one important piece as we look how to combine this in the metastatic setting versus the definitive upfront setting, that there can be differential effects. So this study out of Sam Strober's group at Stanford looked at 30 gray, a single high dose, extremely high dose of radiation, which we don't use definitively, versus 3 gray in 10 fractions. This is the standard palliative dose. So you can see in his study that the 30 gray single dose caused a significant improvement, increase in CD8 T cells and survival, but the palliative 3 gray times 10 did not. But this is what's also very interesting. When they gave that single high dose of 30 gray, but then followed it up with additional radiation, it blocked that effect or abrogated that effect, indicating that when you're inducing a response, additional radiation after that, you may be killing the cells coming into that field, which is an important point. That was in other models. This is actually recent data in head and neck tumor models, which is very nice, demonstrating in this Mach1 line that, again, the higher dose, this is 8 gray times 2, caused improvement in survival, versus the 2 gray times 10 did not. So differential dose effects. Radiation is not one dose fits all. And the immune responses, you can clearly see a significant difference just by doing a difference in the radiation dose and fractionation. So I think that is a very important point as we look at how these studies are incorporating to get advice and input from the radiation oncologist and hopefully a radiation biologist to help understand how to best combine these studies. And some additional truly mechanistic evidence. Why is this occurring? Why would a difference in radiation dose have such a dramatic effect? This is data from Silva Fermenti and Sandra DiMario's group, recently published in Nature Communications, and it showed this very interesting threshold and kind of a gradient of response as the radiation dose went up. What happens is that when radiation can cause double-stranded DNA to enter in the cytoplasm, and that functions, it actually mimics a virus and activates viral pathways to activate immune responses. But what happened when they used higher doses, it induced this factor. This is a DNA exonuclease. It basically chops up that double-stranded DNA so it wasn't present and wasn't able to induce those kind of mimicking those antiviral immune responses. But the lower doses did not seem to induce this Trex protein. So you can see big differences in the double-stranded DNA present in these cells, just dependent on the dose and the fraction. So giving it at this low dose multiple times allowed that double-stranded DNA to exist, whereas the single fraction did not. So quite interesting and provocative data, which may impact potential studies going forward. There's a huge number of studies looking at this, a really established body of preclinical data looking at many different combinations and dose fractionations. But the real question going forward now is, what's the clinical data to support this? I think the preclinical models are exceptional and necessary, but we truly need some clinical data. So this is some of that. Looking at clinical abscopal responses in patients with radiation and immunotherapy. The top is from John Schoenfeld's group out of Dana-Farber, and they looked at a review of metastatic melanoma patients that got radiation plus ipilimumab, CTLA-4, and they looked at the presence for these distant or abscopal responses outside of the radiation field. And interestingly, they did observe those, but they also saw that there appeared to be a dose fraction effect, that the people that got a lower dose or more conventional fractionation seemed to have more of these responses, whereas these higher doses, some of which were single fraction, did not. So maybe that corroborates that. Second study, also from Sandra Demario Silva-Fermenti's group. This was actually a clinical trial, prospective, looking at radiation combined with GM-CSF, a growth factor and cytokine growth factor agonist, and they did see abscopal responses at about 25%. So generally, abscopal responses are rare, but they can be observed, and there's many studies showing that. So what are some of the better trials also looking at this? And this is, I think, one of the better, quite interesting trials. This is a phase 2 randomized study in oligometastatic non-small cell lung cancer. And what does that mean, oligometastatic? Well, that means few metastases. So in this case, they were quite strict. Some people would say less than 5 metastatic sites. In this setting, they said patients with 3 or less metastasis after frontline therapy. And they randomized those patients to physician choice for maintenance, whatever that would be, systemic therapy or maintenance otherwise, or aggressive local therapy. The thought that if there's just 3 of those spots, let's go after them aggressively, either with surgery, a metastectomy, or with focal radiation therapy or high-dose radiation, which was the majority of the case in this study. And then they looked at the results. And quite interesting that the study was stopped early due to a significant improvement in progression-free survival. This was published in Lancet Oncology in the experimental group. You can see almost a tripling in the progression-free survival here in the group that got the aggressive local therapy. So even in this setting of aggressive lung cancer, which was one of the deadliest killers, that there is an oligometastatic state, and aggressive local treatment can improve those outcomes. So clearly, this study begs to add immunotherapy to this, and that study is actually already ongoing. This is, I think, one of the strongest data that's available, looking at the potential benefit of adding radiation to immunotherapy in the metastatic setting. So this is a retrospective review of melanoma patients, and they all got immunotherapy, and some of those patients got radiation, and you can see there was a significant doubling of the overall survival, which is quite remarkable, being this was overall survival in these patients. And so there could certainly be some retrospective bias due to that, but clearly some strong evidence that radiation is doing something here at a systemic level. So a number of other studies, and first off, I also want to apologize for any studies that I wasn't able to list and highlight. There are so many. It's a rapidly advancing field. I certainly apologize. It was not intentional, just due to time constraints. This is a study also by John Schoenfeld out of Dana-Farber, specifically looking at focal high or low dose radiation in patients with squamous cell carcinoma of the head and neck. Thomas Jefferson, pembrolizumab plus 8 gray versus pembrolizumab plus 20 gray in a number of sites, including head and neck cancer. So looking at this fractionation effect, which I think is critical to test. In the metastatic setting, we have a trial in which I'm PI at UCSD. It's a phase 2 looking at checkpoint blockade combined with SBRT in advanced metastatic disease. I will be highlighting some of the data from that study in my talk on Saturday. And then, of course, at Memorial Sloan Kettering, a similar study limited in head and neck, metastatic head and neck, looking at nivolumab plus radiation. So certainly an active area of investigation. So take-home points for this metastatic disease. The preclinical and retrospective clinical data are highly encouraging that radiation combined with immuno-oncology agents may improve progression-free survival and potentially overall survival. However, the prospective data on this benefit is still limited and I would say lacking. Abscopal responses are very rare, but we have to await the results of these ongoing studies to really further define this role or the benefit of adding radiation to checkpoint blockade in the metastatic setting. So switching gears now to the definitive setting, the upfront curative intent. What's the rationale and ongoing studies for this? So what are different ways how they can be combined? Well, certainly with chemoradiation in the definitive setting, you can give immunotherapy concurrently. You could go through a course of chemoradiation and then give the immunotherapy in an adjuvant setting immediately after or soon thereafter chemoradiation. We're also potentially looking at even some induction strategies or neoadjuvant studies which are in development. With radiation alone, okay, so this is in patients that are cisplatin unfit, elderly patients. Can you add immunoradiation without any chemotherapy? And then what about in patients with good risk? This is also another interesting area, going head-to-head potentially with chemoradiation. I think certainly it's quite a high bar. Some of the studies I'll be going over, RTOG 3504, with nivolumab, pembrolizumab, and the key chain. And again, I would be remiss without mentioning Keynote 412, which is a national study using pembrolizumab, also randomizing patients to pembrolizumab with chemoradiation. I think one unique aspect of that study is that they also use an accelerated fractionation as one of the arms, which will help look at that question also. A PD-L1 with avelumab, a Javelin study, a Tezo, and then Durva, which HN004 I'll be going over. So just one slide of preclinical data on this. Certainly the timing can be important. And so Simon Dovetti did some very nice studies looking at radiation, adding in the immunotherapy at what time, giving it right at the start, giving it at the end, or giving it after completion of radiation. And there can be clear differences in these preclinical models where concurrent at the start or near the end was beneficial, more so than the adjuvant. But I think we need to take these studies with a grain of salt. The preclinical studies and the metabolism of the animal tumor models is drastically different from that of humans. The size of the tumors, the radiation doses. So, you know, this is exceptional in demonstrating the proof of principle that you know the sequencing can affect things. But truly, this is just an excellent question that can be addressed clinically. And I think this is one of the exceptional studies going forward with that. So this is Bob Ferris, University of Pittsburgh, which is directly testing that. And I think it's a great, excellent, and elegant study design. You know, randomizing patients with stage 3, 4, AJCC 7, intermediate risk or high risk, and then looking at giving the standard course of IMRT radiation with cisplatin and then adjuvant pembrolizumab versus this concomitant with a 1-week window and number of biomarkers. So, you know, excellent study to test that sequential versus concurrent. This is RTOG 3504. This is basically a phase 1 study at this point. That's its primarily outcome is dose-limiting toxicity and looking at the safety of these regimens. And this is taking patients with oropharynx cancer, intermediate risk, P16 positive, with greater than 10 pack years smoking, stage T2, N2B, N3, or less than 10 pack years with T4, more advanced stage, or N3, or patients with high-risk oral cavity, larynx, hypopharynx, or P16 negative oropharynx. And then they're randomized to a number of these arms. This arm is nivolumab with a lead-in with low-dose weekly cisplatin combined with standard IMRT to 70 gray. This second arm is nivolumab with high-dose pulse cisplatin every 3 weeks with IMRT. This arm is quite interesting, also looking at nivolumab combined with the standard cetuximab radiation with a lead-in dose followed by the standard dosing for radiation. So really looking at dose-limiting toxicity, what's the safety and tolerability and feasibility of these regimens. And then a very interesting fourth arm looking at elderly patients poor performance status, or those with contraindications are unable to receive cisplatin. I think there's certainly still some question, what is the benefit of adding cisplatin in this population? You may have an improvement in local regional control, but that may be outweighed by potential toxicities and morbidity of such. And so looking at nivolumab alone, this is just purely immunoradiation, no chemotherapy in this arm, will be quite interesting to see as well. So excellent study there. So this is Javelin. This is a large phase 3 randomized double-blinded placebo-controlled study. As you know, looking at a number of different sites, moving immunotherapy nivolumab into the locally advanced setting, and this is their head and neck 100 schema. Taking HPV stage 3, 4, again AJCC 7, or HPV oropharyngeal disease with more advanced T stage, and this is upfront treatment, randomizing double-blind to adding nivolumab plus standard concurrent chemoradiation. The primary endpoint here is progression-free survival. This is a large study, about 640 patients, which we're also contributing to and accruing on. So I think what's also interestingly is that nivolumab is an anti-PD-L1, which is effector-enabled. So there could be some potential differences between the use of radiation with a PD-1 antibody versus a PD-L1 antibody, and some differences in the actual biologics used there, which will be interesting to see. And then immune therapy in cisplatin unfit patients. So phase 2 feasibility of pembro plus radiation at UNC, so-called pembro-rad, radiation plus pembrolizumab versus RT cetuximab, again in cisplatin unfit patients, a GORTEX study. NRG has HN004, which I'll go over, and then as Ezra mentioned previously, the REACH trial, quite interesting combination of radiation, nivolumab, and cetuximab versus radiation cetuximab. So quite interesting combination there of biologics. So this is HN004. This is a large study, 533 patients. It's actually a phase 2-3. There's a phase 1 lead-in, and the phase 1 is looking at feasibility. The phase 2 endpoint is PFS, and then it would transition to a phase 3 of overall survival as the endpoint. This is really looking at that population of patients which are elderly, again, poor performance status or comorbidities or contraindications to cisplatin. I think it's a great study to try to address this. It stratifies patients based upon a number of factors: stage, age, form status, P16, and site, and then randomizes to durvalumab concurrently and then adjuvantly for, I believe, 7 cycles versus cetuximab. And I think this is a great population which to test the potential benefit of immunoradiation because chemotherapy, otherwise cisplatin or carbotaxol is otherwise contraindicated. So this will be a great, and also a good comparator arm. Cetuximab is one of the few biologics that was approved for use directly with, specifically in combination with radiation therapy. So this will be interesting to see whether other biologics could be specifically improved or what the differential effects in these groups will be. So, as well as adjuvant immuno-oncology agents after definitive chemoradiation, can we learn from completed other studies in terms of the feasibility, the efficacy, the safety, toxicity? And I think we can. And one of the ones I would like to highlight is the Pacific trial. This is an exceptional trial with durvalumab. This is looking at non-small cell lung cancer. Patients got chemoradiation for lung cancer, and then immediately started durvalumab, assuming they didn't progress on the scan during chemoradiation. But it was interesting, they started 1 to 42 days post-chemoradiation, so it could have started immediately or up to 42 days. And it was a double-blind, randomized, placebo-controlled, durvalumab versus placebo, a double-blind, and these were the outcomes. There was a significant, again, tripling of the progression-free survival in this group by blind independent central review. And I think this is quite remarkable data. This is a major advance for lung cancer, and I think they're going for FDA approval for use of this purely adjuvantly for all comers lung cancer. And so I think this is a great example of how these drugs could be combined and make an impact in other disease sites. Would like to highlight some of the subgroup analysis, which was also quite interesting to look at. First of all, PD-L1 status. there was an improvement in the hazard ratio independent of the PD-L1 status, which is quite interesting because this could be potential all-comers, and whether chemoradiation can modulate the expression of PD-L1, which has been shown, and could that affect the results or help the immunotherapy work is certainly an interesting question, but this would be in all-comers. And then a probability of death or distant metastasis also shows improvement there, as you can see on those curves. And so we're awaiting the overall survival data. As far as toxicities, what can we learn from that? And remember, this was chemoradiation to the lung. And so certainly pneumonitis, after a long course of chemoradiation to the lung, you'd expect. There was an increase in low-grade pneumonitis, or radiation pneumonitis, but there was no significant increase in high-grade pneumonitis. So grade 3 requiring oxygen, grade 4 requiring hospitalization or intubation. So you can see that it was quite interesting, there was not this significant increase. Overall, the rates of pneumonitis are low. What I would say, it's a rare but potentially very serious side effect. In this study, there were grade 5 pneumonitis, even though pneumonitis was known and there was an active pathway to manage it. There were still some patients that passed away due to pneumonitis. And understanding with these agents, especially with toxicities, the immune system can act extremely rapidly. And when it gets activated, it can accelerate its own process. And so, understanding the toxicities and managing them aggressively and immediately can be key to help preventing these high-grade toxicities from developing and occurring. And overall, there was no untoward safety signals identified from using durvalumab adjuvantly after a course of chemoradiation. So as just a summary of this trial, significant improvement in PFS across all pre-specified subgroups, clinically meaningful benefit in the objective response rate, and they had a lower incidence of new lesions. So it was acting outside of the field, of course, durvalumab as a systemic agent, but also including any new brain metastasis, and no new safety signals were identified, so we're awaiting the blinded overall survival data. But I think an important trial that was positive and could be a model for other trials going forward. So unanswered questions with checkpoint inhibitors, what are the best biomarkers? Can we extrapolate data from the metastatic to non-metastatic? What is the optimal radiation dose and fractionation? We touched on that. When and how? It's certainly an open question, and those are being addressed. And in the field, and this is a unique thing for head and neck cancer, as we still do elective nodal radiation, which has gone away in many fields. We still routinely do elective nodal radiation for head and neck cancer. And then single versus combination immuno-oncology. So I'll just touch on that briefly, just 3 kind of recent studies. This is touching on the timing. That, again, when I talked about the different immuno-oncology agents in use, this is data demonstrating that the timing can be dependent upon the agent used. So again, it's not a one-fit-all situation. In this case, the CTLA-4 was more effective when it was given prior to the radiation. You can see in improved survival, but when using an OX40 agent, you could see that actually giving it after was better. So understanding the mechanism, understanding the immunology and potential goals there are key, and how can some of these preclinical data guide that? Still needs to be tested clinically, but understanding that timing is important. This is data from Andy Min's group, published in Nature a few years ago, clearly demonstrating that combination anti-CTLA-4, anti-PD-1 plus radiation is effective. When they used radiation plus the CTLA-4 alone, they saw an upregulation of PD-L1 as an escape mechanism. I think, when I was working at Hopkins, when these agents were first being tested, it was even a surprise that, we were blocking one checkpoint and seeing the activity. And the immune system has multiple different breaks. How could it be that blocking one checkpoint could cause this activity? It was even a surprise from that. So understanding that with the combination agents, blocking multiple checkpoints, but at the same time having a risk for potential increased toxicity, are we turning the dial too far? So how to best dial that in, I think, will be important as we move forward. And then lastly, for the lymph nodes, actually some older data prior to the widespread adoption of immunotherapy, looking purely at the lymph nodes. So here what they did is they took a mouse and they treated a local tumor with radiation, but they cut out the lymph nodes, or they did a sham operation, and you can see that when they cut out the lymph nodes, the local tumor control decreased. And so you clearly need the lymph nodes in order to improve the local control from radiation. Similarly, in a mouse that has no lymph nodes, it also had diminished local tumor control. So this, I think, has some interesting implications for our field size. Do we treat elective nodes? Is it necessary to treat elective nodes when combining with immunotherapy and radiation? That's certainly an interesting question. So take-home points there. For the locally advanced definitive setting, multiple trials are ongoing. There's potential implications for radiosensitization and improved local control, but also dose de-escalation versus treatment field de-escalation. And I would like to touch on that. As we're moving forward, adding immunotherapy to concurrent chemoradiation. Chemoradiation, as I discussed before, is a very difficult treatment to get through for head and neck cancer. And some patients don't make it through. So you can consider that adding immunotherapy to chemoradiation, that is an escalation in therapy. At a minimum, you'd expect to see the additive side effects from the immunotherapy alone. And so just realizing that we are escalating therapy when adding it concurrently, and whether that's needed, given the prior and current focus of looking at de-escalation in HPV-positive populations. So understanding that, I think, is an important point as we move forward. But at the same point, is there a differential toxicity profile? Could it be that that potentially are the outcomes equivalent, but that the immunotherapy plus radiation has a better toxicity profile? Could that be an advantage or a route for approval is potentially possible? I would certainly like to highlight that Dr. Gilson going to be presenting on RTOG 3504 at the plenary session, so I look forward to that. And second to last, just a couple notes on surgery. There are certainly a number of interesting studies looking at this. HN003, this is post-operative, so patients went through a definitive surgery and then had indications, positive margin, ECE, or otherwise high risk for adjuvant therapy, IMRT with cisplatin. So this is adding the pembrolizumab to that adjuvant treatment, looking at that. And so this has been enrolling and accruing. And then lastly, this is one of Dr. Cohen's trials. I think a quite novel and interesting study. This is looking at kind of what we call salvage pembrolizumab. This is for patients that went through a prior course of definitive treatment and now have a recurrence, which is potentially salvageable with a salvage surgery. There's a pre-treatment biopsy, and then they go on to receive pembrolizumab, and then they go for their definitive salvage surgery. And one of the unique benefits of this study is that it includes a window of opportunity immune assessment. You're getting a lot of tissue, the pre-treatment biopsy, and then the entire post-surgical specimen to understand what went on during this window, and then going forward to looking at the disease and the primary endpoint to see the clinical efficacy of using this adjuvantly as well for in the surgical setting. Additional studies, neoadjuvant IO, so immunotherapy with pembrolizumab in surgical resectable head and neck at WashU. Andy Sikora at Baylor and ICANN has a very interesting vaccination study prior to robotic surgery for HPV positive. And Ram Leidner at Providence has this quite interesting neoadjuvant immunoradiation. So almost a trimodality approach as a neoadjuvant immunotherapy combined with radiation prior to a definitive surgery. So a number of quite novel and interesting studies. So take-home points for the surgery, multiple trials are ongoing. Open questions, how does neoadjuvant treatment impact extent or timing of surgery? What are the CR rates? What are the PR rates in this setting when we use this in a neoadjuvant setting? And then I think what's important, and we can also look and take this from other disease sites, when we're giving an induction or neoadjuvant treatment, how does that induction therapy impact your recommendations for adjuvant treatment based upon the pathology? So for example, if they had an immunotherapy prior to surgery and the nodes were negative, could they have otherwise been positive prior to the immunotherapy, and does that impact your adjuvant treatment recommendations? So quite an interesting area and opportunity to look into. Lastly, just some safety considerations. I think I've touched on this throughout the talk. Is there mucositis? So during chemoradiation, if you're adding an immunotherapy, does that change your rates of mucositis, your toxicity in the oral cavity, in the tongue, in the oral pharynx? That's possible. The skin toxicity from radiation can be significant in the neck. Do we see any differential effects in the rash? You saw the patient had some residual rash in the patient video there. Should we watch out for that? We're treating the thyroid with radiation, but if you're adding immunotherapy, does that enhance potential thyroid disease, or if you're treating nasopharynx, does that potentially change your hypophysitis rate? Something to look at. Another quite interesting one, which I think is specific and very important to address for head and neck cancer, is respiratory. We certainly know that a course of chemoradiation can cause aspiration, either during treatment or long-term, and that aspiration and resultant pneumonias can also lead to mortality. And so in the setting of a concurrent immunotherapy or adjuvant immunotherapy, is an aspiration event exacerbated? Do you have a more robust inflammatory response? You know, conversely, could your pneumonia rate go down because you're having an immunotherapy? We don't know. It's something we have to look into. The patient also reported weight loss, fatigue. Fatigue is the #1 side effect from these checkpoint blockade agents, and so adding that during the course, does that prolong the treatment recovery time and need for G-tube and other sorts, and so other differential hematologic changes as well. So this is really the multidisciplinary care piece. We talked about surgery, radiation, but these are the actual treatment providers. But we cannot ignore our speech pathologists, which will be key for helping us address the safety and toxicity of these agents, nutritionists, research nurse, and clinical trial coordinators. Yeah, so just final thoughts, and I'll just, I think we've gone over much of this, but a number of questions were made, and we really look forward to the ongoing studies to help address these questions. Thank you.
We now just move to the Q&A, and as I said, just take a couple of questions. Barbara, let me give you the first one. In your opinion, is there an ideal trial candidate for immunotherapy in the frontline metastatic recurrence setting?
Yes. First of all, I'm quite eager to get access to frontline immunotherapy for my patients. So obviously, the current generation of trials, some of them are up against extreme, and that means that you're, we're saying metastatic recurrent, right?
Yeah, let's talk about that. Yeah.
So you're looking for patients who are going to be eligible for a platinum-based regimen. We do have the 714 study open, which randomizes between nivolumab and ipilimumab nivolumab, and for that, patients don't need to be platinum eligible. So I think across the board, if you can find a trial that your patient is eligible for, I think given the evidence that there is durable impact on survival with these agents, I'm quite enthusiastic about it. The one setting where I might have some caution would be a patient with very bulky local regional disease. If one of the arms involves a single agent immunotherapy agent for which we already know the response rate to be, let's say, in the 15 to 20% range, because these are patients who potentially could lose their airway or have a bleeding complication. However, if you're starting to look at combinations with response rates of 37, 40% that we're seeing in the phase 2, or combinations with chemotherapy, which we anticipate is going to be highly active, there I would not have that reservation.
Yeah, so in those patients where response is critical, single agent immuno, you might shy away from a little bit. Andrew, I'll give you a question. Do you think RTIO, radiation immunotherapy, will replace chemotherapy radiation as treatment for some patients? Will replace chemo-RT?
I think the key word is there potential for some patients. Looking at the elderly, cisplatin eligible, I think chemoradiation is the standard of care, and I think a lot of these studies are early, and it should not be replaced, certainly not off trial, to understand that, because we wouldn't, chemotherapy and radiation has a clear, long history of improving the local regional control, and we don't want to compromise that. So in select patients on trial, yeah.
So still studying it, but let me be provocative. 10 years from now?
10 years from now, I'm definitely hopeful. Yeah, no, I think that in select patients, certainly potentially against comparing to cetuximab, I think we could have some potential beneficial activity, yeah.
Barbara, last word on that? Do you think we're in a different age for curative intent, or coming on to a different age?
Absolutely. Where radiation might be used as the sensitizer and IO would be yes. And I don't think it's going to take 10 years either.
So thank you very much. Thank you, Barbara and Andrew, for wonderful talks. Thank you for attending. Enjoy the rest of your Valentine's Day and enjoy what will prove to be, I'm sure, a wonderful meeting over the next few days. Thanks very much, and thanks to PeerView for organizing this.
Thank you for listening. Download materials and complete the post test for instant credit at www.peerview.com/QES. This activity is supported by an educational grant from Merck & Company, Incorporated. This activity has been jointly provided by Medical Learning Institute, Incorporated, and PVI, PeerView Institute for Medical Education.